province. Thank you. And on this note, I will hand it over to Mr. Sanjeev and Ms. Dina Powell. So quickly, Mr. Sanjeev is a board member of the SCD, and also he has over 20 years of international experience working in the life science sector, launching innovative therapies, devices, and services to address the unmet needs for patients living with rare conditions. Mr. Sanjeev Wadhwani, welcome. And I also have with us co-moderating the next session for the first group of hospitals, Dr. Dina Powell, who is also a board member of the SCD, and she works in the medical field and has produced over 8 scientific publications during her years in academia. Dr. Powell is passionate about using her medical expertise to bring awareness and education in the sickle cell community and advocating for patients and families. Welcome, Dr. Dina Powell and Mr. Sanjeev Wadhwani.
Thank you, Lonray. I think maybe I just a big thanks to Fitan, Maisa, and Warren for coming in out and sharing your stories. I think it's only through your experiences that we can raise awareness and really put attention on strategies and tactics to invoke change for the better. So really a big thanks, I think, on behalf of everybody here. I think the next session really is where we would like to get some more understanding of, how are we improving the quality of sickle cell disease care in our hospitals. And so Dana and I will be co-moderating this session. And maybe I turn over to Dana to introduce our first presenter.
Absolutely. Good morning, everyone. We are so excited that you've taken this time on a Saturday to be here with us. And as my co-moderator has mentioned, Mrs. Sanjeev, thank you so much for our patient panelists that have been so transparent and given us, opened our eyes as to what is needed in the system. So as we move into the next session, it's my pleasure to introduce our speakers from the London Health Science Centre. We have Dr. Ziad Soul, I'm so sorry if I've mispronounced that, a hematologist and transfusion medicine specialist. In addition, presenting with him is Dr. Wasim El-Halabi from the Emergency Medicine Department. This is an emergency physician. And I'll pass it over to my co-moderator to introduce our other speakers before we pass it over to our first set.
Thank you, Dana. So following the first presentation, we will then listen to the Ottawa Hospital Centre from Dr. Alan Tinmud, who will also share experiences from that hospital. And then we will transition to Michael Garron Hospital and listen to Dr. Roseanne Andreou. So with that, we'll go to our first speaker, Dr. Ziad. And Dr. Wasim, I turn over to you.
Hello, can you hear me?
We can.
Yep.
Okay, perfect. Sorry, my audio was delayed. And can you see my slides? I just have a couple of slides.
Yes, we can see your slides.
Okay,
we can.
Beautiful.
If you can just put it in presentation mode, Dr. Ziad, that would be super. Thank you.
Perfect. So thank you so much for the introduction and for inviting me here. I was very excited that this summit was, first of all, happening and for the opportunity to connect with our patients and our sickle cell disease community around Canada. And I really just have a couple of slides. I was invited to speak about our program here in London and some of the barriers that we're facing and some of the accomplishments we've done. And Dr. Wasim El-Halabi has been an integral part of making a lot of these things happen. So London Health Sciences is a quaternary care hospital where we have a large catchment, about 2.5 million people from all the way from Windsor to the Kitchener area, and patients come to us from a lot of areas. When I joined in 2017, patients with sickle cell disease were being seen by kind of spread out among several hematologists, and having trained at McMaster and spent time in Toronto, where they have comprehensive care programs in sickle cell disease care, I knew that London needed something like that. So we opened a clinic in 2017 with full support from our hematology division, and we were initially starting with only about 30 patients, because there's a perception that London doesn't have sickle cell disease. But as soon as we opened the clinic and told the family physicians and everyone, we quickly grew into over 100 patients now. And you can imagine, with the limited resources we started with, we are kind of trying to ensure that we get what our patients need. So the clinic was established as a single clinic. All the patients that were seen by other hematologists converged into one clinic. And the goal was really to provide them with the highest standard of care, following all the guidelines. And then step by step, we had to find all of our collaborators around the hospital who had the expertise to provide what's needed. So first and foremost, we've heard from our patients that the emergency department can be a very stressful place to be spending time in the waiting rooms, and physicians not knowing how to approach a patient. And we have about 75 to 80 emergency physicians in London. So you can imagine having a different physician each time can be difficult. This is on the adult side. So I reached out to Dr. Wasim Al-Halabi, who has a lot of experience in sickle cell disease emergency care, and we established an order set, which is kind of a standardized care set where everyone gets the same care, depending on their presentation. And I'll let him expand on that later on. We also just recently added a Triage Alert. As soon as a patient walks in and their name is put into the computer, it tells the doctors this is sickle cell disease. This is very recent. We also spoke to the medicine team, when patients are admitted, and we realized that there's a variable care. Patients aren't getting the opiates on time, etc. So a standardized care set was made for medicine admissions with all the blood work that's required. Perioperative care, so surgeons and anesthesia were asked to follow specific guidelines preoperatively and after the operation as well. We also spoke with our pediatric colleagues and established a transition clinic. This is where patients in their teens and their early adult years are cared for in a more attentive way, so that they can become more successful adults with a chronic disease following their treatment regimens. We collaborated with SCAGO, who has been instrumental in making our program successful. They provided a lot of clinic materials. They provided a lot of kind of venues to educate patients and make them successful adults, like I said. We had one patient on red cell exchange transfusion, and now we have, almost 10, I think. The care, that therapy has we've become more experienced in it, and we've developed the expertise. We've trained the nurses in the dialysis unit to do red cell exchange transfusion. And we have patients coming from outside London for red cell exchange. We've expanded that now not only to adults over 18, but children 14 to 18. We still don't have the expertise for under 14 years of age for red cell exchange. And finally, we established proper shared care with an area in Ontario that has more sickle cell disease that's unrecognized, which is Windsor. They don't have access to some of the specialized testing, so we still do it in a shared care model. But now there's more care available in Windsor for them. Problems we're encountering have been from the get-go. We don't have the funding for stable access to a nurse case manager. As we know, patients with sickle cell disease have, extremely complex care, multiple specialists, neurologists. We have to coordinate their care not with untrained nurses that change every week. This is the model that they have in London. We need a nurse case manager who's a stable healthcare provider for this population, and the funding has been by donation, which is really unacceptable because it's unstable. And having a patient of this size, we're working on having, hopefully getting some funding from the Ministry of Health for the patient. We also have lack of a dedicated social worker. So for example, when COVID happened, our social worker was whisked away elsewhere to the hospital where they were more needed there, but it really affected our ability to care for our patients properly in the middle of a pandemic. Lack of dedicated administrative support. So, we have to find funding for our administrative support. And, when there's a program of this size, it becomes difficult when when the hospital isn't providing that funding. And then we've noticed that newcomers and students tend to be left on the fringes of society because they just don't have access to stable insurance. So, they literally stop coming to their appointments if they don't have insurance, and they end up in the emergency room. And then we don't have access to all the novel therapies that the Americans have access to, which is, an issue that we're working with SCAGO and other organizations. I do want to let Wasim add a few things from his perspective as well.
Thank you very much. I appreciate that. I'll start by saying that being able to, listen to, your stories and your personal experiences as patients and as family members is quite powerful. And I don't think we, I don't think we get enough of that. That being said, the onus should not be on you as the patient or as the patient family member to have to, impress upon us the severity of the disease. That's something that as practitioners, we should already know. What I'll say is I've trained, where I trained was in Newark, New Jersey. So we had a very large sickle cell population. And, luckily for me, I was exposed to multiple sickle cell patients almost daily. And having now transitioned my practice to Canada, there are multiple differences that I can see. And I think first and foremost, we as a whole, I would say have, a lack of exposure. From a purely volume perspective, I can say personally myself, I don't think I've seen a sickle cell patient within the last year or so. And I think, part of the issue, at least with London Health Sciences Center, is that, with this kind of, for us at least, infrequent patient presentation, the knowledge in terms of caring appropriately for you as sickle cell patients can wane or may not be as up to date as required. So I think Dr. Ziad reaching out and initiating some advanced and appropriate care in the emerge from the hematologic perspective has been good for us. As he mentioned, the sickle cell order set was worked on together, and I think it's quite helpful in terms of, at the very least, immediately recognizing that a sickle cell patient has presented to the hospital, and then there are immediate orders available for treatment, including pain control, and then necessary contacts. In the past, patients with sickle cell disease may have been admitted to hospital without a hematologic referral, and that would have left them with care on the floor and in the hospital that is not as good as we can possibly provide. And so that's been corrected. But at the end of the day, I think the lack of exposure contributes to a couple different problems. I completely agree that the pain that you would experience or you feel as sickle cell patients is under-recognized by the majority of medical personnel. And that's, that may be secondary to, the chronicity of the condition, leading to you having particular painful crises that are, you're not rolling around on the stretcher. As somebody mentioned earlier, you may be working on a laptop, and despite that fact, there is tremendous pain. There is a continuous, pain that we just don't recognize as non-sickle cell patients. And part of improving sickle cell care, at least from my perspective at London, is impressing upon our practitioners that despite the fact that sickle cell patients may not be rolling around on the stretcher, may not be calling out in pain, they are still in tremendous pain and do require adequate pain control. Part of the part of the opioid epidemic over the last 10 to 15 years, I think, has contributed in providing a negative stigma towards some patients who are on chronic pain medication, and that is something that is affects the whole of medical care. But your personal patient stories and family stories are quite powerful, and I think going forward, part of improving care and continuing to improve care are regular updates with best practices for sickle cell management, and some impetus on us as emergency physicians to identify and bring in patients or patient advocates who can tell personal stories, because those are memories that stick and that can last an entire career. One last thing I'll mention is I had a physician, Melanie Johansson, who was a very strong sickle cell advocate when I was in residency, and she spent a good amount of time basically hammering into the trainees there that despite the fact that, once again, you may not appear as though you're in extreme pain, that pain is real and that pain needs to be managed appropriately, and that stuck with me. So I try to impress that upon my learners, but we need better teaching. And I think part of the collaboration between hematology and emergency medicine at LHSC has started to push us in that direction, but there's definitely more work required.
Yeah, those are all excellent points. And I did want to add to that by, pointing out that the previous speaker, one of the patients had said, you don't want to bring undue attention, and that's the opposite of what I tell my patients to do, because I see my patients sitting, they were triaged low because they again weren't rolling around on the bed. They're just rocking and like holding their arm, being stoic, like closing their eyes. And I get there to the waiting room and I say, you have to self-advocate. You have to advocate for yourself. Go tell the triage nurse you need care. And our order set can only go so far. It says, if there's fever, you need antibiotics within 30 minutes. If there's pain, give so-and-so. But the pain report has to come from the patient. And I spend a lot of time with my young patients who haven't learned to advocate for themselves, telling them, you need to be loud, not necessarily disruptive, but just, politely advocate for what you need. I think that's a major point. So bringing undue attention, sometimes it's not undue, sometimes it's very warranted.
Yeah, I think that's a good point. I think as well, a lot of the old guard kind of sees patients who are, a little louder as attention seeking or exaggerating their symptoms for their own personal gain. From the conversations I have with residents and with staff and just my personal experience in the emergency department, I feel like a lot of that comes from some of the staff that has been working a little bit longer, especially some of, I've heard quite a few times some comments regarding some of the nurses not taking their patients' pain seriously. And, personally, I noticed that more in some of the my nursing colleagues that have been around quite a bit longer. And so, hopefully with better education and as we continue to learn more and more, this is something that is, continuously improved. But I would agree, you should be a strong advocate for yourself, but at the same time, you need to be comfortable and confident in the fact that you're going to have somebody who is empathetic and understands and can provide you the necessary treatment. So that part is on us.
Amazing. Thank you so much, Dr. Ziad and Dr. Wasim, for your excellent insight into the HCP side of treating patients, some of the challenges that you foresee and ways in which it can be maybe addressed on your end. So we appreciate that. Sorry, I don't know if Dr. Ziad, I see you still have a slide up. I'm not sure if you still had more, it's thumbs up, perfect. So excellent, excellent presentations. And I just want to acknowledge, we do see the questions in the chat. We will queue them up for our Q&A session that is after our main speakers from the Group 3 hospitals. So thank you so much, keep the questions coming, and we will address them at that point. So I'll pass it over to my co-moderator to reintroduce our second set of speakers so that we can keep the ball rolling and get more insight from our HCPs on how we can improve the quality of sickle cell disease care in our hospitals. Thank you once again, Dr. Ziad and Dr. Wasim.
Thank you, presenters. So in transitioning to the next hospital, I'd like to introduce Dr. Alan Tinmud, who's a hematologist at the Ottawa Hospital. And Dr. Tinmud, can you hear us? Are you on? Do we see your Zoom picture? Come on.
Hopefully, can you hear me?
Yes, we can. We can hear you well. Thank you for joining. I'd like to transition over to you when you're ready.
Okay, I'm just looking at sharing my slides here. So let me get them up in the presentation mode. So while I'm doing that, so can you see that? And am I using the correct slides?
Yeah.
Correct.
Okay, I just wanted to make sure there's two sets of slides on my screen. So again, I want to thank you very much for inviting me to be part of this meeting and for organizing it. I think it is incredibly important to have these kind of meetings, and as a treater of sickle cell, of individuals with sickle cell, I feel that it's always so important to continue to hear stories from the patients, and and hearing them in a forum like this is really important. Hearing them every day, or when I actually see the patients in clinic, in the emergency department, when they're admitted, is equally important. And that point about listening is so important, and it always reminds me how important and how much work there still is to do. So just as a brief introduction to myself to begin with, I'm a hematologist at the Ottawa Hospital. I've been there, I hate to say, almost 20 years now. Similar story to Dr. So when I arrived, there was no standard program. And one of my senior colleagues recognized the need potentially to centralize the care and said, we have maybe 5 patients here. It would be great if they were coordinated under one person. I had spent part of my fellowship which was in transfusion medicine, working in the clinic at the Toronto General, and so I did have some experience. And certainly over the last 20 years, we've seen our program, as I'll sort of try to outline, expand dramatically.
This is too wide.
So just as a quick introduction, so our program here at the Ottawa Hospital really has been an evolution over really now probably 15 to 20 years. We are the regional program for both the Ottawa region and Western Quebec. We see patients from the Gatineau region and around that area. Currently, we follow about 300 patients, including 250 patients with sickle cell anemia, as well as 50 patients with thalassemia. We estimate we probably get 20 to 30 new consults a year. In Ottawa, at the Ottawa Hospital, we have 2 campuses. Like many places, we have the Civic Campus and the General Campus, which is the one on the right of your screen. That's where all hematology is located, including our hemoglobinopathy program. Though patients can obviously present to either campus, or, as people outlined, to some of the community hospitals in our area or in our region. We're a fairly large hospital, about 56,000 admissions a year, 800,000 outpatient visits, and 150,000 emerge visits a year, as we are the only quaternary care center for this area. So our sickle cell program, when I think about it, I think about it involving many different aspects that interact. So we have our clinic that we have, the hemoglobinopathy clinic, as I described, where we see the patients. But this interacts with a number of other areas in our hospital. We have our inpatient ward, which is dedicated to benign hematology. We have our apheresis program, where we do red cell exchanges. We have specialty clinics that we refer to in terms of ophthalmology, respirology, chronic pain. Pain management is obviously critical. We try to work closely with both the acute pain service and the chronic pain service. And then obviously the emergency department is also a critical aspect of the care and of sickle cell patients in Ottawa. So just briefly, our hemoglobinopathy clinic, it represents, it's at the general campus. Currently, we run it 1 half-day clinic per week. We've had a dedicated clinic probably for about 10 years now. The number of physicians has grown from myself to now actually having 4 different physicians who work in the program. We have a nurse who is only part-time, and again, that's one of our greatest barriers to care, only probably a 0.2 FTE. We do have social work, which has been great benefit over the last few years, but still not adequately resourced. We do have a number of other specialty clinics who we do really have a very formal relationship with, and I think that's been a great advantage and something that has progressed over the years and has improved our care. We have our chronic pain clinic, which we work with as well and make referrals to help improve with the pain management for some of our patients. We have a dedicated ophthalmologist who sees most of our patients, and we have a respirology clinic that we also refer to, and one clinician there in particular has a great interest in sickle cell disease. Our apheresis program is also an important part, and I consider actually part of the hemoglobinopathy clinic. It's actually run by myself and one other physician who are members of the hemoglobinopathy program. Our sickle cell nurse, in the time when she's not the hour she doesn't have devoted to sickle cell, is actually part of the apheresis program. So there's quite a bit of overlap with that program. We use the red cell exchanges, obviously, for acute indications such as stroke, chest crisis, patients who are very sick in the ICU with multi-organ failure. We also use it as a chronic exchange program, and this includes patients who have had stroke or at high risk for stroke, previous acute chest syndromes, and probably the largest indication is patients who have recurrent pain episodes that we haven't been successful in controlling by other means. And right now we have about 34, 35 patients who are on chronic red cell exchanges. In terms of the sickle cell, important part is the chronic is managing pain. Obviously, it's not the only part of it, but it's a critical aspect of the pain, and one that that is important to do our best to manage appropriately and use all the resources that we can. So obviously we have routine management in our clinic, and this would include, using prescribing pain medication, making sure that's available to patients so that they have it, hydroxyurea to reduce the frequency and severity of crises, and then, as I mentioned, the red cell exchanges. Sometimes, though, despite all this, we still have significant issues, or individuals have significant issues of pain that we need more help with, and this is where the chronic pain clinic has been a great addition and resource for us. And we've developed a good collaboration over the years. Reasons that we may refer those patients is when they have frequent visits to the emergency department and hospital admissions, as one of the speakers mentioned. That's the last place that most individuals, all individuals that I talk to with sickle cell disease, they want to be. So how can we maximize our treatments to make it so that patients don't need to go there, and the chronic pain clinic have greater expertise and knowledge to help us with that. So that's been a real important and aspect, and something that we're still working to increase our interactions, because I think this is an incredibly valuable resource, though unfortunately it's one that's also overtaxed and underfunded and under-recognized for the important work that it needs to do, for patients who have chronic pain, not just sickle cell disease, but obviously that's many other conditions. And they can offer a number of aspects of treatment with chronic pain. They have resources that aren't available, and knowledge that aren't available to us. They have a full-time psychologist. They help try to have alternative or complementary strategies for managing pain. So we're not saying not using pain medication, but obviously pain medication itself isn't the only thing to help manage pain. And speaking to the points before about being quiet and in the emergency room and other things, something that I always try and impress upon my colleagues is that these are actually things that we talk using the computer or teach in these ways. You know, using a computer, being on the iPad, these are forms of distraction. This is actually ways to help manage and cope with the pain that patients have developed themselves or that, you know, have been encouraged to use and can be effective. And so they shouldn't be seen as signs that patients aren't in pain. This is how they've learned to manage with the pain. In terms of the other, I think, evolution in our program at the Ottawa Hospital is that we also have a dedicated benign hematology service. So this is a service that just admits patients with hematologic problems, non-cancer, non-thrombosis, and as a result, it's a very small service. It generally has 3 to 5 inpatients in a year, but this is where our sickle cell patients are admitted. Previously, they had been on the hematology ward with all the cancer patients, and unfortunately, I often felt they didn't have enough priority or visibility. The service is too large to begin with, and you know, and there are so many competing interests with patients with acute leukemia that patients with sickle cell disease weren't getting appropriate attention from there. So in this service, we have 9 hematologists who attend on the service, so a relatively small number, and approximately 50% of the weeks are actually covered by physicians who work in the hemoglobinopathy clinic. So I think this does help improve our continuity of care, our knowledge of the patients and the disease. We're still not perfect by any means, but I think this helps. We also will consult or have the ability to consult our acute pain service to aid in the pain management where appropriate, offering things such as the patient-controlled analgesia, ketamine, or lidocaine when our usual treatment protocols aren't being effective for managing the pain. To speak specifically to sickle cell disease in the emergency department, we average probably about 2 to 27 visits per month, on the average 10 per month, and that's between the 2 campuses. Generally, we direct patients that come to the emergency department, and I certainly hear all the comments of the speakers earlier sharing that, you know, the reason we do that is we feel there's greater knowledge, experience, because we still don't get a large number of visits. That's 6 over the course, you know, that's, you know, 10 over the course of a month. You know, that is still, you know, 3 shifts a day, 300 shifts, large number of nurses. So again, individuals, you know, specific individuals working there still don't have a great exposure to patients with sickle cell disease. So if we have greater experience and knowledge of the general, that's helpful. But it does mean that if patients are coming to the other areas, the disadvantage drawback is they have even less experience at the civic emergency department or in one of our community hospitals. But it does provide us the advantages. If there's a need for admission, then they are admitted again to our ward with greater experience. If there's a need for a hematology consult, for a red cell exchange, those services are available at the general where they are. So we have also implemented a sickle cell anemia protocol in 2008. And I think this really did help to improve the care. So patients who present with sickle cell disease who present to the emerge, they're triaged like all other patients. Once they should be triaged as a high priority. There's still work to be done to improve the triaging to make sure patients are triaged appropriately. Once they are admitted or in one of the beds in the emerge, they're then assessed by the nurses. The nurses can actually initiate the algorithm, so they do not have to wait to be seen by an MD. And I'll go into this in a little more detail. They do have to have the emerge doc sign off on the protocol before they start, but that can be done prior to the physician assessment, which I think is added to the care. So unfortunately, was a big change that occurred for us in June 1st of 2019. We switched over to an electronic medical record with Epic. Epic is an electronic medical record that is becoming more and more widely used in the US and in Canada. It's now being used at Sick Kids, at CHIO, the Children's Hospital in Ottawa, and will be coming to UHN, and it's in Alberta, and many other hospitals will probably be introducing it, but it does involve a landmark change and a change in all the processes. So this, we did have to look at switching over our anemia order set to an electronic order set. It really was a replication of our current order set. As I mentioned, the order set can be initiated by the nurses after approval with the physician prior to actually being seen by the physician. And one of the key things that I wanted to point out was that the inclusion criteria, as demonstrated by the arrow, is that all patients who have a history of sickle cell anemia who present with signs and symptoms consistent with what the patient recognizes as their typical crisis. That is our inclusion criteria. So again, it is listen to the patient. If the patient says they have that this is their sickle cell crisis, then they should be started on the anemia protocol. Excuse me. Of course, there needs to be caveats and reasons why, and times when it isn't initiated, and if there are concerns that are being raised, or flags where we need to manage things differently. So part of the first step in the anemia program is to provide pain medication, analgesia as appropriate. We have a standardized protocol, either for giving morphine or hydromorphone with an initial dose, and then follow-up doses after that to try and get initiation of pain protocol. So this is great. Everyone comes in, gets when it's initiated, gets a standardized dose. The disadvantage is that the same formula cocktail probably doesn't work as well for everybody. So some people this may work very well, and other people's it may not be the right dosing. So this is still something to work on, but I think having something standardized has helped to improve the time to getting first dose of medication. We're very fortunate, actually, as this whole issue was being raised by the Sickle Cell Awareness Group of Ontario, that I went back and I actually found out that one of the residents in the emergency department had actually done a recent project assessing the sickle cell anemia protocol and what had happened with the transition through Epic, transition to Epic. And so here, this is the graph that I showed before earlier, the number of admissions. And really the point of this was looking before and after the introduction of Epic and seeing how we were doing with the management of individuals with sickle cell presenting to the emergency department. So this is what's called the Runtime Graph, and what it just shows for each month what the average time to first dose of analgesia was from presentation. And what you can see is there's quite a bit of variability. Part of this variability is due to there can be very small numbers, and so one patient can affect things. The larger numbers, we probably see a flattening of this line, but I think the bottom story is this, is that we're not achieving our ideal times, the target of 1 hour, we're not achieving it, and sometimes we're quite a bit greater than that. So variability is a big concern. Even as you can see at the end on the right-hand side, in June and July, there were, as part of the project, there were reminders sent to all eMERGE department staff to use the protocol and to educate about it. And despite this, we actually didn't see an improvement. So it tells us that we need still to do more than just the reminders. Overall, what does our data show? Well, we had about 2 hours to a first dose, again, with great variability. We're at least happy that the time to after the Epic rollout did not result in any further delays of care. Ideally, I think with an electronic medical record, we'd like to see an improvement, but we didn't see a significant improvement. It was slightly better at 1.9 hours after the rollout. Probably the most telling and important thing, I think, from this study that was done is that is that they looked at how often the protocol was used when individuals with sickle cell anemia presented to the emerge department. And the biggest concern is that this was only 53%. So I think this again speaks to the issue of it isn't a common, still in Ottawa, it's not a common presentation. Not everyone remembers that it's present, that the protocol is there, and it doesn't get initiated. But interestingly, when the protocol is implemented, there is a significant shortening time to the time to first dose. 1.6 hours, still not our target, but it is significantly better than when the protocol isn't used. So what are kind of our next steps, just to close with? So we want to still look and reevaluate our sickle cell anemia protocol. Is there anything we can do to improve it? Probably even more importantly, is there anything we can do to improve its use with the electronic medical record? Can we look at prompts, flags? One of the problems with any electronic tool is that there are flags, warnings that are popping up all the time, and you actually, the immediate reaction is just to click and close them so you can do what's next. So there is flag or fatigue. So we need to make sure that we have something that's effective and not something that's just ignored. And one of this, and there's also a new section that is being implemented, which is called an ED care plan, where we can actually have documented pre-planned treatments that are seen to the emergency department physicians, so that we can, in conjunction with patients, develop what is the plan that works for them. So not just that one size fits all program, but something that's more individual to make sure that patients are getting the optimal treatment when they come in. More importantly, or not more importantly, but equally as important, we need additional, things for our program. The biggest thing is we need increased nursing and administrative resources, and with the help of the Sickle Cell Awareness Group of Ontario, they've raised it to the government, and I'm really hopeful that we will actually get some additional resources, and this is probably the biggest thing that we need to improve things. We could improve having standardized admission orders we're looking at, and we're also reevaluating our red cell exchange program and the introduction of what we call depletion exchanges. So with that, I'll stop and thank you again for inviting me to speak on behalf of all the people as part of our program in the emergency department, especially Megan Fu, who did that work, who has given us some real data on it, on the experiences, or at least of sickle cell care in Ottawa. So with that, I'll stop sharing my slides.
Thank you, Dr. Tinmud, for your presentation. Really great to see a local protocol also in place, zooming in on that patient perspective for inclusion criteria. I think that's also unique in terms of how the perspective of the center is looking at that, and the fact that it's also a living document in the hospital, and you're looking to continually look for ways to update it based on the measurements you're doing in terms of impacts. So really great insights there. Just keeping us moving along, I'm going to transition to Dana to introduce us to our next presenter.
Thank you, Sanjeev. So next, we have from the Michael Garron Hospital in Toronto, we have Dr. Roseanne Andrio, a benign hematologist. We are excited to hear from you, Dr. Roseanne, so please take it away.
Are you able to see my screen or?
Not yet. Feel free to share screen. Yes.
Okay. Can you see something now?
Absolutely. You can feel free to go in presenter mode and we see everything. Thank you.
Hold on from beginning. Everything good?
Perfect. Thank you.
Okay. I don't know how to get back onto myself. You'd think after a year of doing this, there I am. Hello. I am very, very, very honored to be here and to represent Michael Garron Hospital. We are a small community hospital in Toronto, and we work really hard to try and help our sickle patients as best as we can, and to create a very comforting and positive environment in our hospital. So I'm hopeful that you guys will enjoy my presentation and kind of share what we've been doing. I've been there for about 15 years and we've really worked hard on this program. So I'm hopeful to preach to the people who already know how important sickle cell disease. And I was very moved and touched by the presentations by Fitzy, Mesa, and Warren this morning. And it really points to the fact that although we all work really hard to try and make this experience and the healthcare system experience for sickle cell patients and their families as positive as we can, because this is a huge problem for them, we need a lot of work to still be done. I want to review what I feel are barriers to sickle cell care, and how we at Michael Garron have tried to address these barriers to try and make our program as successful as we can. So I'm going to tell you a little bit about what we do and how we can hopefully get better. So sickle cell disease, as we all know, is a very common genetic condition that affects many people worldwide. In Canada, we have at least 5,000 people affected, with children born every day with this condition. There are huge costs, and these are costs that are personal costs, patients experiencing it, in addition to costs to the healthcare system. Patients with sickle have significant chronic pain that they deal with every day. They have frequent hospitalizations. They lose employment opportunities. School and work days are limited. And then sometimes they are isolated and feel the stigma, especially when they go into healthcare systems where they're not treated with respect. So we want to address all these issues as best as we can to try and make everybody's experience as positive as possible. The barriers to care that we have seen is there's a lack of knowledge about disease by patients. Obviously, you know, programs like SCAGO and patients support groups have helped to alleviate that, but I think it's important as a physician that we aid in constantly keeping our patients up to date about the literature with regards to sickle, and also learning from them. There's a lack of knowledge about the disease by many providers, and we have talked about this through the other presentations. There's a lot of physicians who have limited exposure to patients with hemoglobinopathies, and it's important that that be addressed at the level of medical schools, you know, training and beyond. There's a lack of a comprehensive care system. There are many aspects of sickle cell disease that impact every part of your body. So it's nice to have a comprehensive system, a comprehensive care team, access to social work, nursing, and other physician providers in order to be able to establish a good care plan for patients. Patients with sickle have chronic pain and they need narcotics, and that is part of the disease. And, you know, unfortunately, that comes with, you know, providers and other people who believe that as patients who are dependent on these drugs are addicts, which is a complete false. So we have to work to dispel the myth of this perception of addiction in patients with sickle cell. I think frequent visits to an overcrowded ER are negative for everyone. The ER obviously, you know, doesn't want to deal with patients who have chronic pain, and patients with chronic pain do not want to be there. So if we can find a way that we can kind of mainstream their visit, or kind of have a way for them not to go to the emerge as often, I think that would be the best. And also biases, and this is explicit biases like Fitzianne was describing, you know, nurses who kind of just brush them off, that they do not have, you know, real pain, etc., or even implicit biases that we don't know within ourselves, that we are expressing to our patients. We need to become more aware of these situations. So this is us. This is Michael Garron Hospital. It was built in 1929. We are located in East Toronto, and we are a division of the Toronto East Health Network, which is a group of like community health teams, family health centers, nursing homes, etc. We have a catchment area of about 400,000 people, primarily a lot of immigrants. We are a community teaching hospital, meaning that we are affiliated with the University of Toronto. We have a lot of family medicine residents coming through our clinics, in addition to internal medicine and hematology fellows, which I think is a great place for them to become educated about hemoglobinopathies. Our vision is to create health and build community. We want to develop innovative partnerships with our patients, our healthcare providers, and our community. Our values are compassion, integrity, courage, and always to be accountable for our actions. We're pretty small, so I'm very honored that we're able to present here compared to all of the other important programs that have been described. We have about 250 acute care beds. We have a crazy busy emergency department with about 250 patients per day, with over 67,000 visits per year. So it's very important that there's a streamlined approach for sickle cell patients to go through the emergency department. We have many departments of excellence within our institution. So our group ourselves is 1 benign hematologist, me, 3 malignant hematologists, we have 3 oncologists, and we have an amazing nursing, clerical, and laboratory complement that helps us. This is us. This is prior to COVID, disclaimer there. This was our last party, December 2019, right before COVID came, and we're very close and we all really like each other and get along. And I think that has a huge impact on our patient care experience. So to address each of the barriers, in terms of improved knowledge, our patients have access to good literature about the disease and implications. We have them have support and connection with sickle cell organizations like SCAGO, and we've created a kind of a connection with other sickle cell patients. So as I'll go on a little bit later on, we have patients who drop in and get hydration and narcotic therapy in our clinic. We tend to bunch all the sickle cell patients on the same day, ideally, so then they can form friendships and a support system. And I think that really helps for them and for us. In terms of our providers, it's very important to educate everyone as much as we can. So it's important to educate our care team. So that's primarily our nursing staff and our pharmacy staff. We have a good relationship with our emergency room staff, and we would present prior to COVID, because now everyone's ridiculously busy, but prior to COVID, we would do twice a year updates to the emergency room department about sickle cell care. And we always do grand rounds at least once or twice a year to educate our internist colleagues. In terms of comprehensive care, what I think works at our institution is there's one care provider, i.e. me, who knows our patients very well. And I think because of that, we've been able to establish an excellent relationship where I know our patients very well and they know me. We trust and respect one another. And I think that works really well because I think they feel safe to share anything that they have that's bothering them, whether it's personal in addition to medical with us. And I think that relationship is what makes them happy getting care with us. There is consistency with our nursing staff. So there is one benign hematology pod that I have in our clinic. So there are 6 chairs. I have the same 2 to 3 nurses who work with me all the time. And for the patients who are coming in and getting sickle cell hydration in clinic, they get to know our nursing staff very well. We've established a narcotic contract for our patients with one provider. So they have a narcotic contract with me. And I've created good documentation for their narcotic care plan for providers. So it's documented in their power chart record. So should they present somewhere else within the institution, or if someone else from another institution wants access to this, what they need in terms of their narcotic needs, they can access it through Connecting Ontario. Basically, we have to be accessible to the patient so they're able to connect with me pretty readily and easily, or at least access our clinic very easily. And we both have to be accountable. So they have to present to clinic when they say they're going to present to clinic. I have to be there when they need me to be there. And it's that mutual relationship that makes it work well. We're very fortunate that we're in Toronto and we have access to the hemoglobinopathy group at UHN with Kevin Koo and Richard Ward. So we have like super experts on sickle cell disease at our fingertips. So if we need an exchange transfusion, or if one of our patients is very ill, like during this year, we had one of our patients had to get transferred in a significant crisis from the ICU over to Toronto General to get an exchange transfusion. That was very easy for us to facilitate. In terms of chronic pain and the perception of addiction, this is something that I think all of us who care for patients with sickle cell have to deal with and gets us very angry. Sickle cell disease is a chronic pain condition. You're going to need opioids. That is the nature of the disease. Unfortunately, lack of knowledge about the disease leads to stigmatization of patients with sickle, and they're labeled as drug seeking. They're seen as frequent flyers. Oh, it's that sickler again. And they put them in the corner in the emergency department and they don't get attention. And because of experiences like this that happened to a few of my patients over the past, I would say 15 years, is why we changed our program a little bit to try and have kind of a set protocol for these patients, to try and avoid the emergency department if we can, in order for them to get the care and not have delays in care. We feel that, the stigma leads to delays in treatment delivery. They tend to be underdosed of their opioids, even though they tell the care providers in the emergency department what their opioid needs are. And as a result, sickle cell disease is not managed as great as it should have been. And then in terms of frequent ER visits, obviously the ER is overcrowded and it's very busy. And unfortunately, I agree with all the other speakers today who said that it's super important for you to be a very strong advocate for yourself as a sickle cell patient. And it doesn't matter if people label you as being disruptive or loud. It doesn't matter. You need to voice your concerns. And I think some people mentioned about going to patient relations. That is the only way change will be made. If you do not go to patient relations and complain about an experience, changes like we've tried to enact in all our institutions won't be made. So it's very important that you speak your truth. We don't want you to have long waits with inadequate pain control. Patients, as a result, and we've heard, they delay going to the ER because they know that they're going to be ignored and disvalued. And because of that, they end up presenting in worse crises. And so we looked at, is there a way that the ER can be bypassed? Can there be a coordinated plan between the ER and hematology? So because we're a very small community and we have a small number of patients, we're able to do a little bit of unique things. So our patient population of sickle patients is about 25, and we have about 10 regulars. So 10 people who come in often, and then the other 15 are people who come in when they're really in crisis, or don't come in unless, they want to check in once a year. It's nice to have one physician, which is me, as a main provider for the patient's sickle cell care, and with liaison as necessary for Toronto General. We have a great relationship built on trust and respect. We have education to the patients and also from the patients. We learn so much from our patients, and it's important to always keep an open mind and listen to what they have to say. We educate our nursing staff, our emerge staff, and our internists. In terms of our pain management plan, I think it's important for us. We have a documented narcotic contract. We have documented notes of what the patient's narcotic requirements are in their medical record and what to do should there be a need for escalation. And we're very fortunate that we have a pharmacy in the hospital that we have a really good relationship with, and they establish a good relationship as well with our sickle cell patients. So sometimes if I'm away or if I'm not in hospital and they need their narcotics, we're able to get them the medication because of the good relationship that we have with the pharmacy and the patients. We also have a pretty good relationship with our emergency room physicians. They've been very responsive to a lot of the changes that we've done. Obviously, me being available and responsive to the ER physicians also helps. We have this new, like a texting system that has started during COVID that I think has improved the quality of care of our patients, because the emergency docs can text me directly and let me know one of my patients has been seen in the emergency department, and I could give them advice or put in orders myself into the system. And that way, the narcotics will be given in a timely fashion. Something that we've done that's unique, I think, to us, I don't know if other centers do it, is We like to bypass the emergency department if possible. So if there is a way that patients during the day between 7:30 and 4 when we're open can call in and come into the clinic, we can try and see if we can provide them with hydration and narcotic support within our own clinic to try and circumvent, obviously, them going to the emergency department. And then if necessary, that they need admission, to admit them from my clinic into the inpatient unit. And that kind of helps to bypass the whole emergency room, I guess, relationship. We have hydration and narcotic support as needed. Our nurses know the patients well. I'm there, or someone else who's covering for me would be there, who also knows the patients through our experiences. And also there's a support system with other sickle patients there. We try, if people come in for hydration regularly, we try and book them all on Mondays. And then that way they kind of get to know each other, which is great for them, and having a support system. Over the past year, one of the Emerge physicians has started a pain management / addiction program, which I think is great, because she's been very good at helping us optimize narcotic medications for our patients. And I think that helped, having an emergency physician who is very interested in sickle cell patient care and making sure their pain is well controlled. Obviously, we always have to work to eliminate our own biases. That's in every aspect of medicine. And also we have to be accountable. Both the patients have to be accountable, as do us, the providers. I mean, in terms of next steps, obviously education is great. You know, the past year and a half has been horrible for everyone in the healthcare system. So we have not been able to do a lot of conferences for nursing. So I think our education is lacking a little bit. Also, we're very short-staffed in terms of our nursing. So that is impacting care a little bit. I think ultimately having focus groups with patients and care providers in order to optimize what they think would be the best case scenario for them getting great care is also important. We have not been sophisticated enough or have had enough time to create these beautiful sickle cell care pathways that the other hospitals have done, but I think that's something that would be nice to adopt, and maybe we can borrow some other people's care sets as a starting point. And obviously continuing to build our relationship with Kate, the Emerge physician, and her pain group. So in summary, I feel sickle cell disease is super important and affects many Canadians. Patients with sickle cell will have lifelong interactions with the healthcare system. So because of that, we need to make sure that they are happy when they come to the healthcare system and don't feel as jaded as Fitzianne has been. And hopefully her experiences will change as time goes on. We need providers to be more knowledgeable, to be more respectful, and to be cognizant of their own biases. It's great if you have a consistent physician who knows you to provide comprehensive care, and then they act as your advocate when you have challenges. Obviously, comprehensive care programs are important, but in order for that to happen, we need money. And money is always the big issue. So I'm glad some people from the ministry are on this chat, because ultimately, I think to have centers of excellence in every institution would be ideal, or any cluster of institutions would be great, and we need money to have that happen. So thank you for allowing me to share our story with you.
Thank you very much, Dr. Roseanne Andrea, for your excellent overview there, giving us some insight into the importance of comprehensive care for our patients, just that standard level of care, knowing that these patients, all of us basically have lifelong interactions with the healthcare system, and ensuring that is optimized from an HCP perspective in terms of like the education, the empathy, the respect. Thank you for giving us that great overview from an HCP perspective. Excellent. So now we will love to transition into our Q&A session. So we would like to invite all of our panelists and speakers from this Group 3 hospital session to feel free to put your cameras on, and we are going to start addressing some of the questions that our guests have been including in the chat. So we want to encourage everyone to keep putting your questions in the Q&A chat box, as well as in the chat window. So we'll start off first with one of our first questions from one of our guests. So Isfan has asked, did you try to work with sickle cell clinics in core hospitals to establish a patient per professional-led design center of excellence network? So anyone from our panel, feel free to answer. So just repeat that question. Did you try to work with sickle cell clinics and core hospitals to establish a patient per professional-led design center of excellence network? So any of our HCPs, I don't know if you feel that you've been able to influence this, the sort of relationship with the patient professional development towards providing a network that works well, maybe universally or even just locally to help address some of the issues that the patients have been presenting with.
I think for our institution, it's very different because we're in Toronto. So we have access to UHN, like Toronto General, and their Center of Excellence very easily just by a phone call to, one of my hematology colleagues. So we don't have an official relationship. It's just that if I need help or if I need an exchange transfusion or if I need advice, then I'll send our patients over there. Also, some of our younger patients who want to be more with the Center of Excellence, they still come with me and hang out if they need their treatments and hydration and narcotic support. And then once a year, they go check in with the UHN hemoglobinopathy group, to get more specialized care kind of more, they have a more comprehensive team versus just seeing one person.
Thank you, Dr. Razan.
Yeah, so at Al in Ottawa, I think the interaction, because I think all of us, outside of maybe, centers such as, the Sick Kids or UHN, this is all part of what we do. We just because of the size of the patient population, this isn't the sole focus of what we do. And so learning from colleagues, obviously learning from patients is an important thing to do, and doing that in a place where we can share group experiences is certainly valuable. Obviously meetings, conferences like this as well. There is, I think most people are aware, there is a national sickle cell group that has, regular annual meetings, that does have updates that come out, sharing information, has rounds as well that have been put on as well. These are all valuable experiences, because I think that we all, I don't know that I would consider ourselves a center of excellence. We're a center of certainly of experience. We strive to keep and offer the best possible care. We're looking at trying to get innovative strategies, including gene therapy. We're hoping that we'll have a trial that will be available for that. So yes, we want to do that, but we also recognize that we're limited in our experience, and that's where interactions with colleagues and again patients can help to improve that. So I think that's really important, and it's something that I have seen evolve over time, but it's still something that I think we need to continue to improve. It helps with our advocacy as well to have groups and organizations and meetings like this, clearly.
Absolutely. Thank you, Dr. Allen.
Maybe we can transition to the next question, Dana. Is there a need for mental health or spiritual support in the ER for patients presenting with symptoms or crises, or part of ongoing management, self-management support of this complex condition? If it is needed, is it part of the current best practice suggestions? Maybe Dr. Ziad, would you like to address that one maybe? Oh, sorry, Dr. Ziad, I think you're still on mute.
Okay, I think it's working now.
Yes.
Yeah, it's an interesting question, and often in the emergency room, the mental health aspect of care is done by a social worker, and at least in our center, more often than not, that social worker is the clinic social worker, not the emergency department social worker. We at least haven't accessed that resource. It's certainly something potentially worthwhile looking into. Oftentimes, the acute presentation in eMERGE requires upfront a lot of heavy clinical medical care before more attention can be given to the mental health issue. That's usually more of a chronic or episodic situation. But I think it's an opportunity, definitely. It's something worthwhile talking about. We certainly access social work resources for all sorts of other disease, conditions that present to the emergency room. So this shouldn't be excluded.
Thanks, Dr. Ziad. Anybody else? Dr. Tinmud, Dr. Andrew?
Yeah, no, maybe if I could just add to that, I actually think that support is key for the visits to the emergency room. I think the testimonies from the patients who spoke at the start of this clearly outlined that going to the emergency room is a stressful event. It often doesn't go well. Even if it goes well, it's probably not ideal still in many situations. Question is how do we provide support? And I think it's on many different levels, as Dr. Zola has pointed out, is that the spiritual and those part are maybe things that are difficult to address, and certainly right away with the other medical issues going on. However, the support from early on is important. In our ideal world, we would have a full-time nurse, and this is what we're hoping for, who would be able to go to provide that support in the eMERGE. The reality is right now, as a clinic, we can't provide that. Dr. Zoll mentioned that the first point of contact is the clinic. Well, we don't have the ability to provide that for our patients, and it's a real lack. And there is advocacy that's needed, just because, again, there may not be as much experience, and there are clearly biases that affect care there. So I think the support in the eMERGE is absolutely critical, and I think I would hope that our clinics would be able to provide some aspects of that support. But right now, at least in Ottawa, we don't have the resources to do that, which is really unfortunate.
Thank you, Dr. Tinmud.
Sorry, I just wanted to mention, Mrs. Lanray, would you unmute yourself and feel free to contribute? As I see your hand up, we want to make sure we don't forget our panelists to have their hands up. So we see you. Sorry for the delay.
Thank you, Dr. Powell, and thank you so much for great moderation. I really want to thank all the three speakers from the three hospitals. An excellent job. I want to really commend Dr. Adrio from the Michael Garron Hospital. Even though they are now receiving special funding for their program, but yet they have made sure that and maybe not many patients, but the patient with sickle cell that they do serve, as much as possible could bypass emergency. That's huge. I really want to commend that. And I'm wondering if the other hospitals can also maybe, learn to see what they can do along that line. Maybe some sort of a program that will allow patients to, as much as possible, bypass the eMERGE department. Because again, when with a disease as sickle cell disease, we don't even want patients to be going to the emergency department anyways, right? But then we do know that life is life and these things happen. When they do go, they need to get the right care at the right time. But then how do we ensure that they're not, what can we all do differently in the hospital system to ensure that less and less patients with sickle cell, will be showing up in the emergency department? That's my one comment. And I want to thank Dr. Andrew for doing that already. With the Ottawa Hospital, I want to commend Dr. Harlan Timouth on his presentation. I really love the idea that now they've moved post the EPIC, the time to first, and I guess here, based on your presentation, now is from 2.3 hours to 1.6 hours, something like that. That is a huge improvement. However, I believe, and correct me if I'm wrong, that in your hospital, the nurses are also empowered to provide analgesia quickly. I'm thinking targeting under 1 hour. So Dr. Tinmud, is that true or not, that the nurses are able to give analgesia quickly before the patient see the doctor?
Yeah, no, thank you, Lanre, for that question. So I think I tried to highlight in the presentation that is correct. The nurses can give analgesia first, and so but they still have to be in a bed, and they have to have been assessed by the nurses. The nurse make an assessment if they meet the criteria for the inclusion, which is based on what the patient is telling them. Is this my typical sickle cell crisis, and that there aren't any other external factors? The patient's really sick, they're looking septic, with an overwhelming infection, in which case the doctor needs to see them right away, and we don't actually want to create a delay by starting the protocol and thinking that appropriate treatment is being given. But in the settings where it's appropriate, the nurses can then go to the physician and say, I have a patient here in a typical crisis, they meet the criteria, I want to start the protocol, and that includes initiation of the medication as I outlined. With that, our goal is definitely to improve and reduce our time. The numbers you referred to shows that when that protocol is used, instead of being 2.3 hours, we're 1.6 hours, but that still isn't our goal or our target. So that's why we're looking to say, how can we improve it? So first thing is we need everyone to be using the protocol when it should be used. That clearly isn't the case. And then the second thing is, even then we need to still reduce our times. How can we improve things? And there are issues there that are probably related to sickle cell disease. And then there are issues there that are related to emergency department care and the overwhelming demand that they have on it. But we need to work with both of those issues, recognizing to see how we can help achieve those goals.
Thank you.
Yeah, and if I could just answer that one point is I also was incredibly jealous of the description of the program at East General and the ability to have a bypass. It's something that we looked a number of years ago when we actually received some funding to do a pilot program where we were able to had funding for a year to have a full-time nurse. And our goal with that, one of the stated goals was at the end of the day, we wanted to work, towards improving our care and maybe to getting a day hospital again with the bypassing of the emerge. And that is still an ideal we'd like to have. The reality is, if I have a patient right now who has a low hemoglobin that needs a transfusion today, it's in the medical daycare, that's the same setting that we would have to do a day hospital. I usually can't get the patient in that day. It may be 48 hours to get them in for an urgent transfusion that day. We don't have the place or the resource to be able to do that. And it isn't a reality. I would say chemotherapy is being delayed. Again, it's the same unit. Patients aren't meeting those needs. We just don't have the physical resources. Having said that, doesn't mean that we need to stop looking at that possibility. In Ottawa, there has been a commitment to build a new campus, which is that will be built by 2027. And in that, we did ask that as part of the medical daycare unit, that we would have enough space and enough beds that there would be something for kind of swing space and a bed or two available. I'm worried that by the time we get there, the space that was allocated to it, well, again, you plan for 10 years, capacity for 10 years out, and you find you're over capacity within 2 years or even before something is built. So I'm worried that's the case, but we'll continue to advocate to try and have something, because I agree a day hospital model would be wonderful to have, and I think would address so many of the issues or help to address so many of the issues with care of sickle cell patients in the emerge and with pain, with acute pain.
Thank you, Dr. Tinmud. I've spoken with you and your team many times, and I know you're very passionate in improving the quality of sickle cell care in Ottawa area. So I want to thank you. And I know that you're working to improve the time to analgesia. I know the clinical handbook suggesting 1 hour maximum. So I know with what you're doing, you will get there. So thank you so much for the great work, and we'll continue advocating with you to get the resources that you do need. So thank you. Right.
I think ultimately, sorry, it's the resource issue. Like even at our clinic, although we work really hard to preserve our 6 chairs, those 6 chairs are used for everything benign, right? And we're using the same clinic that is where the patients are getting chemotherapy. And Cancer Care Ontario does not provide funding for benign hematology. So, many times over the past 15 years that I've been there, I've been, encouraged to get kicked out of those 6 chairs because they need that money from Cancer Care Ontario. So it's a constant struggle to keep those chairs, right? So I think ultimately it's all about funding, and this is such a real problem, and any kind of extra funding that we can get from anyone is necessary to preserve, the care that patients are receiving. And in terms of the drop-in kind of program that we have, we're very fortunate that, our patients are well cared for and our whole team knows them well. So it's very easy when Katrina, who's on this call, calls and says, hey, I'm not feeling well, can I come in? And our, Elsa, who answers the phone, knows her, sure, and I know her, and the nurse knows her. So we have a very a family-oriented approach to the care, and that's great. But sometimes even that doesn't work. So recently, a patient of ours, got sick in the middle of the night, and she had to come in. And then she didn't get great care in the emergency department, although we have all these checks and balances in place. And until her daughter, who is also a patient of mine, called me in the morning and said, this is what happened to my mom overnight. And I was able to connect with the Emerge and the nursing team. She went, 6 hours with very little pain medication, which is ridiculous. So it's like a constant battle. And I mean, I think here everyone is doing the best we can, but we can't just say, oh yeah, this is a great program, this is a great program, which they're all great and everyone's working really hard, but we need to battle every day for this cause.
Thank you. Thank you so much, Dr. Andrew. And I think with what I'm hearing, we need to invite you to the next Ontario Hemoglobinopathies Patient Association meeting so that we can know our best to advocate for what we need to advocate for next. So thank you. I'll pass it back to Dr. Dana. Thank you.
Thank you very much. It was an excellent discussion. We just have time for one more question. So I'd like to open that up to the panelists. Could regular pain monitoring using patient-reported outcome measures and a treat to target approach improve pain management? Maybe I'll pass it on to Dr. Roseanne, Andrea. I don't know if you want to take this one for us. Could regular pain monitoring using patient-reported outcome measures and a treat to target approach improve pain management? It's coming from one of our guests on the line today.
I mean, I don't know kind of the logistics of using that formal speak, in terms of what I do. My patients tell me how they experience pain, and they write down kind of the pain that they've experienced and the situations within which it happens. And then I titrate the medications accordingly. I think, they always have a pain monitoring schedule, right? So I take what my patients tell me as face value, that their pain is well controlled with this regimen, yes or no. If it's not, then we up titrate slowly and then hope to control the pain. And then if we so they just document how much they're using in terms of their breakthrough, and then I up titrate or down titrate accordingly. I don't use any formal pain monitoring plan. Maybe I should be, I have no idea, but I just kind of take it what they have as face value, and then I up titrate or down titrate accordingly.
Thank you, Dr. Roseanne, Andrea. I think we have Istvan. Istvan, I see your hand up. I'd like to address that. Do you want to come on live and ask the continuation of your question? We have a little bit more time and we'd love to hear what you'd like to ask our panelists today. Feel free to unmute your line and you can address us with your question. Oh, I think he's having, maybe you're having a bit of difficulty with the mic option, I see. Mic icon. Okay, so maybe I can try to facilitate the next question that you have asked. Actually, I'll pass it over to Mr. Sanjeev. I think you have the fourth question, because I think he's mentioning here, and I'll read from the chat. This is the question that we just asked. He meant this in the ER, this sort of like pain management procedure in the ER particularly.
So it's maybe it's again, Alan. I think patient-reported outcomes are critical. They're critical in that we be turning to more and more of these in terms of monitoring our care, and that's the outpatient clinics, but also the emergency department. So part of the protocol that we have includes asking the patient to report their scales. The question is do we have the best tools for that? So I think commonly used is, what's your pain on a scale of 1 to 10, and asking patients with that. So you ask it where to start, you give the medication, how does that improve things? For pediatrics, there's the Oucher scale, which I think is also used, obviously not familiar with that as much as a pediatric. So there are pediatrics ones, and that one's just looking at different faces and which face describes your pain the best in terms of the scale. What I frequently see is that patients have had 1 to 2 doses of medication, and then when you actually talk to them, well, what's your pain been like? Well, it came in, it was a 9, it was an 8. What's the best pain control that you've had since you've been in the emerge and you've been assessed? And it's a 6. And then where are you now? So we're using patient-reported outcomes. I think they're commonly used. Where I don't think they're used appropriately, though, is, or as we're not getting the benefit from asking these questions, is that people aren't using it then to titrate the medication. So if the pain went from 8 to 6 and then is back up again, well, we probably want to improve that. So we want to go from 6 and then we want to go to 4, right? We want to keep it going down. So 6 is not appropriate, so that means additional dose of medication. Or if one only went from 8 to 7, repeating the same dose 4 hours later isn't going to do an awful lot. So again, we need to do that. And our protocol allows them to give repeated doses every 10 minutes in a short interval to try and improve it. And the only way you can use that appropriately is by having a patient-reported outcome, because that's when you know whether I should be giving that next dose 10 minutes later. But it isn't used, I just see from the experience. So that's, again, one of the things that we can and will look to try and improve, is not just the time to first analgesia, but then when we're giving the analgesia, that we're achieving the goals we want to. And the only way you know that is by asking the patient and using some tools. So I think patient-reported outcomes are incredibly important as part of our routine care, especially in the emerge department, but also in the clinics as well. And I think we all do it at least informally, and formally, if we did it more formally, maybe we could, if there was a better way, we'd benefit in that setting as well.
Thank you, Dr. Tinmud. So let's go to, I think we have time for just one last question. This question is, in the SCD protocol for admissions, has there been a collaboration between the patients, patient relations, and HCPs to implement these best practices for optimal care? Maybe Dr. Soul, do you want to? Oh, I think you went back on mute. There we go.
Can you hear me?
Not anymore.
Can you hear me now?
Yes.
Okay. So I think I didn't hear the first part of the question, but it was saying in the admission order that was developed, was patient relations involved? Was that a question?
Correct. So in the SCD protocol for admissions, has there been a collaboration between patients, patient relations, and HCPs to implement these best practices?
So yes, so this was mainly medicine and hematology. Patient relations was not involved because it's purely a clinical order set. Anesthesia was involved in terms of in the chronic pain clinic to find ways to access pain medications when the pain is more chronic. But yeah, so it's basically based on standard practices that are available and published in terms of getting the right antibiotics, broad spectrum antibiotics, strong opiates, having things like non-steroidal anti-inflammatories, not only opiates. So it's definitely a multidisciplinary approach. And then there's things like consulting hematology, social work, etc. So that in that sense, the mental health of the patient was stated clearly in the order set. In general, patient relations is not really doesn't have much to add to orders for patient care, when they're admitted. Unfortunately, oftentimes it's after they leave in terms of reporting what happened and how it happened. It's a really good point because we have identified deficiencies in some parts of the order set. Some patients need intensive opiate doses where certain parts of the hospital will say, no, sorry, that's too high of a dose, or if you need me to give IV opiates, we can't do it in this wing of the hospital. You have to go to the ICU to get on a monitor. So those kinds of things are, structural barriers where, we almost have no say in what the nurses are allowed to infuse or not. So that's where not necessarily patient relations, but more leadership in the hospital steps in, or, bringing special pumps and monitors for the patient. We have things like patients need a warm blanket, and they wanted to bring from home their warm blanket, which is electronic. They plug it into the wall. The hospital says, well, you can't plug stuff from home into the wall because it has to be tested by our electrical engineers. Like, how would I have thought of this, right? So there are structural things that are beyond our control sometimes, where, not necessarily patient relations, but more, leadership and individualized, personalized medicine folks need to be involved to allow them to happen. So I think we're a long way to go from a perfect order set that encompasses everything the patient needs. But that's where a hematologist needs to be consulted that knows this patient. You can't necessarily leave them under the care of the general medicine team who, does not have the expertise to handle what's required by themselves without consultation from the hematologist. Yes, our order set, I would say, is in constant revision and changes. It's not a final version.